Welcome to the CPD program organized by the College of Anesthesiologists and Intensivists of Sri Lanka. It is my great pleasure to introduce today's speaker, Dr. Rashini Vidanage. Dr. Vidanage is a senior lecturer at the Department of Surgery, Faculty of Medicine, University of Kelaniya, and a consultant anesthetist with specialized expertise in transplant anesthesia and critical care. She's attached to the Colombo North Teaching Hospital, Ragama, and the Colombo North Center for Liver Disease, where she's actively involved in the perioperative management of complex hepatobiliary and liver transplant patients. She completed her MD in anesthesiology and further strengthened her expertise by undertaking a clinical fellowship in liver transplant and hepatobiliary anesthesia at the Queen Elizabeth Hospital, Birmingham, United Kingdom, which is one of the world's leading liver transplant centers. Throughout her career, she has contributed significantly to liver and renal transplant services in Sri Lanka and has been actively involved in research publications and national academic presentations in transplant anesthesia and critical care. Today, she will deliver a highly relevant presentation entitled Liver and Anesthesia, Practice Essential for Safe Practice. The session will take us through the essential principles of hepatic physiology, perioperative risk assessment, pharmacological consideration, intraoperative management, and postoperative care, providing practice guidance for the safe anesthetic management of patients with liver disease. Following the lecture, we'll continue with two interactive case discussions where Dr. Vidanage will help us apply these principles to real-life clinical scenarios, bridging the gap between evidence and day-to-day anesthetic practice. I encourage everyone to actively participate and we'll take all your questions at the end and make the most of this valuable learning opportunity. Please join me in warmly welcoming Dr. Rashini Vidanage. Over to Rashini.
Good evening. Hope you all can hear me, right?
Yes, we can.
Okay.
Yes, thank you. Thank you for the kind introduction, Dr. Mathan. And again, I would like to welcome you all for the CPD program conducted by the College of Anesthesiologists and Intensivists of Sri Lanka. So today we are going to discuss about the liver. Right. So in my talk, initially I will touch upon the basic physiology and anatomy of the liver, which the basic facts the anesthetic wants to know, need to know. So this is kind of the knowledge you already have. So I am just going to record the knowledge. And then we'll talk about the pathophysiology of liver disease, how it impact the other organ systems, and then how we manage the patients with liver disease in our day-to-day practice. And at the end, I would like to answer any questions you have. Also, you can add any questions into the chat box. So going into the hepatic physiology, there are a variety of functions fulfilled by the liver. Because of this, liver becomes one of the important organ in the body. So if I'm to classify the functions of the liver, there are synthetic functions, metabolic functions, storage functions, excretory and secretory functions, also detoxification and defense functions. So we'll go through one by one. Synthetic profile wise, liver produce the plasma proteins, mainly albumin. So as you all know, albumin is a very important protein which is needed to maintain the osmotic pressure inside the intravasculature, so which will affect the fluid balance, as well as it acts as a transporter for many drugs as well as endogenous substances like hormones. And then the liver produces some clotting factors like factor 1, 2, 5, 7, 9, 10, and 11. Apart from that, globulins are also produced in the liver, which involves in immunological functions. And energy substrate wise, most of the gluconeogenesis happens in the liver. So liver produce glucose from glycogen. And apart from that, liver produce cholesterol and some lipoproteins as well. So these are the major synthetic functions of the liver. Metabolic functions wise, as I mentioned earlier, glucose is produced mainly in the liver by gluconeogenesis. So there's a glycogen storage in the liver, and when the body needs, this glycogen is metabolized into glucose by the liver. So, for example, maybe during fasting, the glycogen stores can be metabolized into glucose. And the fatty acids are broken down by the liver into ketone bodies, producing some ATP energy. Then the excess amino acids are metabolized in the liver, producing ammonia. Right? So those are the metabolic functions, endogenous metabolic functions. And then liver plays a major role in drug metabolism as well. So there are two main reactions, phase 1 reactions and phase 2 reactions. In phase 1 reactions, that is mainly oxygenation reduction, and the drug is made water soluble. When it goes through the phase 1 reaction, drug becomes water soluble, where it can be excreted via urine. And in phase 2 reaction, that is mainly glucuronidation and sulfation, the drug is made lipid soluble, so it can be eliminated in the alimentary tract. Then storage functions wise, as we mentioned earlier, glycogen is stored in liver. So in a healthy liver, about 100 grams of glycogen is stored, where it can be mobilized as needed. And micronutrients wise, iron, that is ferritin and copper, are stored in the liver. And there are disorders where the storage disorders of these micronutrients, there are clinical manifestations. And fat soluble vitamins, that is vitamin A, D, E, K, are stored in the liver for long-term usage. Apart from this, liver acts as a blood reservoir. So liver can release about 450 ml of blood. So if it equals about 1 pint of blood in a situation like hypovolemia, right? So it acts as a reservoir, blood reservoir as well. So excretory functions wise, the hemoglobin in expired red cell is converted to bilirubin in the liver, and then it is converted to urobilinogen, which can be excreted. And there's bile production. The bile is produced from cholesterol in the liver, and it is secreted. So bile will help to fat emulsification and absorption, and also absorption of vitamin K. Detoxification functions wise, so the ammonia, the metabolism of amino acids, the end product is ammonia, which is a toxic metabolite, and there are some ammonia absorbed from the gut as well. So this toxic metabolite is converted to urea in a urea cycle, which occurs in the liver, which can be excreted safely in urine. And apart from that, there are continuous breakdown of circulatory hormones like aldosterone, estrogen, and insulin, which again happens in the liver. Immune function-wise, there are Kupffer cell which lines the liver sinusoid, and they do phagocytosis of the bacteria coming from the portal circulation. So those are the kind of main functions of the liver. So as you can see, because of this variety of functions in a liver disease, these functions can be affected to a certain degree depending on the how bad the liver disease is. So then ultimately it becomes systemic disease. So there are systemic manifestation of the liver disease. So we'll discuss that in a while. Uh, Talking about the hepatic blood supply, it has this special dual blood supply. About 25% of the resting cardiac output is received by the liver, and from that, 75%, that is majority of blood supply is from the portal vein, which which drains from the alimentary tract. So it's a low pressure system, and it's the oxygen content of this portal venous blood is low. So it provides only about 30% of the oxygen consumption of the liver, but it is rich in nutrition. And the rest of the blood, that is 25% of blood, is delivered from the hepatic artery, which is a high pressure system. And then it provides about 70% of the oxygen consumption of the liver. When we consider the regulation of the liver blood flow, there are special mechanism which we call the hepatic artery buffer response. When there's a reduction in portal venous flow into the liver, there will be reduction in blood flow to the liver. So there will be increase in hepatic artery blood flow. There will be hepatic artery dilatation, and hepatic artery blood flow will be increased to maintain the liver perfusion. So this happens because of like accumulation of adenosine, which is a vasodilatory substance. But in a case where there's a reduction in hepatic artery blood flow, there will be no compensatory increase in portal venous blood flow. So we call this semi-reciprocal mechanism. We call it hepatic artery buffer response. And if we look into the structure of liver, so liver is made of these millions of these tiny hexagonal shape lobules, liver lobules. So if you look into that liver lobule, the central part is, we call it central vein. It is a branch of a hepatic vein. Right, and this corner we call is portal triad. There's a branch of portal vein, hepatic artery, and bile duct. Right, and the liver cells are arranged in rows like this. And this diamond shape structure is the functional unit of the liver. We call it liver acini. So this unit is divided into 3 zones, as you can see. Zone 1 has got highest oxygen supply because it is somewhere near to the hepatic artery. And zone 3 has least oxygen supply, but the highest metabolism occurs in zone 3. So in a case of liver ischemia, zone 3 get ischemic before zone 1, right? So this is again the close view of the same structure. As you can see, this is the central vein or hepatic vein, branch of hepatic vein, and this is the hepatic artery, branch of hepatic artery, branch of portal vein, and bile canal, bile duct. So blood flow from this into the central vein, and bile flow from central vein towards the bile duct. So this is a countercurrent mechanism to make it more effective, right? So this is about the anatomy, physiology, and the blood flow of the liver, right? moving into the classification of liver disease, there are three main entities of liver disease. So this is important when we manage patients in our uh, clinical practice. So first entity is acute fulminant liver failure, where there's a sudden loss of almost all the functions of the liver. So in a previously healthy patient, right? So previously liver was healthy, but there are sudden loss of maybe total function of the liver. So we call it acute or fulminant liver failure. So it is characterized by this triad of clinical features, that is jaundice, coagulopathy, and hepatic encephalopathy. And then you have chronic liver disease. That is, there's progressive disease over a period of time, progressive injury to the liver. And then it results in liver regeneration, nodular regeneration, and fibrosis. We call it cirrhosis. So if you see a cirrhotic liver macroscopically, you can see these macronodules and micronodules. That is due to regeneration of liver cells. And this chronic liver disease can be divided into two, that is compensated and decompensated. Compensated is the patient is asymptomatic. Although there's a chronic liver cell disease, patient is asymptomatic. But in decompensated stage, patient is symptomatic. So the classical symptoms are jaundice, ascites, hepatic encephalopathy, and GI bleeding, right? And the third entity is acute on chronic liver failure. That is rapid onset of deterioration in hepatic and extrahepatic organ function on a background chronic liver disease. So in a patient with chronic liver disease, there will be acute onset of organ failure, either liver or extrahepatic organ failure, right? So out of these entities, the acute liver failure, decompensated chronic liver cell disease, and acute on chronic liver failure carries high perioperative mortality and morbidity, right? So this is the basic classification of liver disease, right? So going into the multi-system impact of liver disease, we'll talk about the cardiovascular system. So you will see a hyperdynamic circulation in patient with liver disease. So there will be impairment of hepatic clearance of vasodilatory substances, mainly nitric oxide, which is a potent vasodilator. So there will be widespread vasodilatation, reducing the systemic vascular resistance. So these patients have low blood pressures due to reduced systemic vascular resistance. Mainly the diastolic blood pressure is low. So then this lower blood pressure is sensed by your renin-angiotensin-aldosterone system, and it get activated, and also there will be activation of ADH secretion. So there will be a lot of fluid retention, right? So then the patient's intravascular volume will be increased. So both these factors will lead to hyperdynamic circulation. But if you consider, even though this intravascular volume is increased, there will be relative hypovolemia due to reduced systemic vascular resistance. The patient, absolutely there's no hypovolemia, but there will be relative hypovolemia, right? And if you take this patient can have compensatory tachycardia due to this low blood pressure. But if you take a patient with chronic liver cell disease, most of the time these patients have bradycardia, not tachycardia. That is because we start them on beta blockers to control portal hypertension and variceal bleeding. So that is why most of the time, if the patients are followed up and on treatment, they usually have bradycardia. But if the patient is not on beta blockers, you may be able to see this compensatory tachycardia. Uh, so what are the effects on myocardium? So this entity we call cirrhotic cardiomyopathy. So due to the impairment of metabolism of these various toxic products, there will be cardiac remodeling causing cirrhotic cardiomyopathy. So we can predominantly see is the diastolic dysfunction leading to impairment of ventricular filling. And there could be a prolongation of QT interval as well. So clinically, we will not be able to see these patients are not symptomatic usually because the heart pumps to a low resistance circulation because systemic vascular resistance is low. The afterload is low. So clinically it will not manifest at rest. So the patient will not be symptomatic. But in an event of stress, this cirrhotic cardiomyopathy can be evident. So for example, under anesthesia, or maybe when the patient is in sepsis or in hypovolemia, you may be able to see the manifestation of cardiomyopathy. So you have to keep in mind if you are anesthetizing a patient with liver disease to keep your vasopressors ready. Otherwise, during induction, patient can go into cardiovascular collapse. Right? In the respiratory system, there are two distinct entities. One is hepatopulmonary syndrome. In hepatopulmonary syndrome, what we see is patient's oxygenation is good at supine position, but when they become to erect position, there will be hypoxia. Patient will desaturate. We call it orthodoxia. Right? So what happens is there will be the same as for the systemic vasodilatation, there will be vasodilatation in the lung as well. There will be intrapulmonary vascular dilatation. Right? So this blood flowing through this vascular dilatation will not get oxygenated. Right? So that we call them shunts. Right? In a supine position, the effect of gravity on pulmonary blood flow is less. But when the patient stands up, the effect of gravity on pulmonary blood flow become most. So then these shunts become evident. So the patient will become hypoxic during in erect position when they stand up. And if you give oxygen, what will happen? Because these shunts are not oxygenated, this blood flowing through these shunts are not getting oxygenated. So how much you give oxygen, there's no point. So then this hypoxia will not improve, right? So this is classical hepatopulmonary syndrome. It is not common, but we can see in some patients. It's a rare kind of clinical feature. And platypnea is what is patient experience, patient symptoms. So patient will complain of dyspnea or shortness of breath when they stand up, right? So then other entity is portopulmonary hypertension. That is occurrence of pulmonary hypertension in a patient with non-patient with portal hypertension without any other cause, right? So this is thought to be due to vasoactive remodeling occurring in the pulmonary vasculature. And due to the pulmonary hypertension, there will be right heart strain, and patient can go into right ventricular failure in the perioperative period. So when there's a patient with chronic liver cell disease, it is a mandatory to do a 2D echocardiogram to evaluate whether there are any features which suggest pulmonary hypertension. If there are features which suggest pulmonary hypertension in your transthoracic echocardiogram, then we have to do a right heart catheterization to exactly measure the pulmonary pressure. So that is how you exactly diagnose the portopulmonary hypertension. And other effects on respiratory systems are like reduction in FRCA due to ascites, and they can commonly have pleural effusion. So both these uh, lesions can cause restrictive pattern in ventilatory mechanics. And you have to be careful when you position the patient, especially for induction, to minimize the effect on respiration caused by ascites. And if these ascites and pleural effusions affects the respiratory mechanics of the patient, or if the patient oxygenation is affected by this ascites or pleural effusion, then at that point we consider draining of ascites or pleural effusions. And this rapid sequence induction we'll discuss in a while. And gastrointestinal effects of chronic liver cell disease, the esophageal and gastric varices is kind of a common finding. In chronic liver cell disease, there will be portal hypertension. So blood find its own way to bypass the liver because the resistance for blood flow is high in the liver. So then that you see the varices. These bypass pathways we call varices, right? So we see varices commonly in esophagus and gastric area and also in rectum also. Caput medusae is also varices, right? So during perioperative, these varices can bleed, causing catastrophic bleeding. And then ascites, which is kind of a cardinal feature in liver disease. So there are several causes for ascites. First thing is portal hypertension. When the portal pressures are high, there will be more ultrafiltration of fluid into the peritoneum. And then due to the low albumin level, the intravascular oncotic pressure is less. Then again, there will be fluid leakage. And also, there will be fluid retention due to activation of RAS and increased ADH secretion. So all these factors will lead to ascites. And these patients with ascites are more prone to get spontaneous bacterial peritonitis, and they can easily go into sepsis and septic shock during the perioperative period. So we try to optimize this ascites with diuretics, and if you can't, if it is indicated, sometimes we consider paracentesis before going for an anesthesia. And then the classical renal manifestation in liver disease is hepatorenal syndrome. So hepatorenal syndrome is a functional impairment of nephron. There's no structural damage. There will be functional impairment of nephron. This is due to the low blood pressure caused by low systemic vascular resistance. This is sensed by your kidney, and then there will be renal vasoconstriction to increase the renal perfusion. So it ultimately leads to reduced renal perfusion caused by severe renal vasoconstriction, ultimately leading to hepatorenal syndrome. So there are two types. Type 1 is rapid and acute onset, rapidly progressing with high mortality. Type 2 is usually associated with refractory ascites. It is slow onset and chronic decline. Apart from this hepatorenal syndrome, these patients with liver disease are more prone to get acute kidney injury during perioperative period as well. So we talk about renal protection during perioperative period. NSAIDs are strictly contraindicated. Nephrotoxic drugs, especially antibiotics and IV contrast, better to avoid. And we discontinue ACE inhibitors or receptor blockers preoperatively. And we try to maintain the adequate mean arterial pressure as well as adequate volume during the perioperative period to maintain renal perfusion. So this will reduce the risk of hepatorenal syndrome as well as acute kidney injury. And metabolic derangement wise, hypoglycemia. So as we discussed earlier, there's glycogen storage and gluconeogenesis happening in liver. Both this will be impaired in liver disease. So the patient will end up with hypoglycemia. Hypoglycemia is a cardinal feature in acute liver failure or acute on chronic liver failure or maybe decompensation. But we usually don't see hypoglycemia in patients with chronic liver cell disease. And then the other problem is dilutional hyponatremia. Due to the excess ADH secretion and activation of renin-angiotensin system, there will be a lot of fluid retention. So the patient will have dilutional hyponatremia. So the problem we encounter here is during the perioperative period, we will be giving a lot of IV fluids, antibiotics, albumin, blood and blood products. All these fluids contain high amount of sodium. So we can iatrogenically increase patient sodium level within a short period of time, causing osmotic demyelination. So this is kind of a known complication, and we had case report even in our centers as well. So you have to be very careful about this hyponatremia during the perioperative period. And again, hypoalbuminemia, as we discussed, which will interfere the pharmacodynamics and of the patient. To how to manage these cases, like we will be monitoring blood sugar very frequently if the patient has severe liver disease. So it's not hourly blood sugar monitoring. Maybe sometimes we have to monitor blood sugar every 15 minutes if the patient is in acute liver failure, to prevent hypoglycemia and avoid rapid infusion of high sodium containing crystalloids. Monitor serum electrolyte closely in the theater and post-op perioperative period. Then, what is the place for Hartmann? So, Ringer's lactate in patients with liver disease. It's kind of a commonly asked question. So, as you all know, Hartmann's or Ringer's lactate contain lactate as a buffer. So, this lactate is metabolized in the liver. But if there is a severe impairment of liver function, the lactate metabolism is also impaired. So patient will end up with lactic acidosis if you continuously give fluid containing lactate. So in these cases, we prefer to give a fluid something like sterofundin, plasmalite, or maybe even 0.9% saline, rather than giving Hartmann solution. But this is only in severe liver disease. But if the patient is not having severe liver disease, maybe in chronic liver, not decompensated chronic liver cell disease, we can safely give Ringer's lactate, but you have to be mindful to monitor the lactate levels. Neurological complications wise, these patients are more prone to get hepatic encephalopathy and increased ICP. So this hepatic encephalopathy is kind of a very prominent and cardinal feature in liver failure. But in chronic liver cell disease also, patients can have subclinical hepatic encephalopathy. So what happens is, as I mentioned earlier, the amino acids are broken down in liver, producing ammonia, which is a toxic metabolite, and from the gut also there will be absorption of ammonia. So if the liver is normal, this ammonia is converted to urea, which is non-toxic and which is excreted in urine. But if the liver function is deranged, there will be derangement is this ammonia conversion, and there will be a lot of portosystemic shunts. So the ammonia absorbed from the gut will bypass the liver and directly will be added to the systemic circulation. So this ammonia will cross the blood-brain barrier, and it will convert glutamate to glutamine. So both this ammonia and glutamine will cause cerebral edema, increase intracranial pressure, and also neuronal dysfunction. So that is how the hepatic encephalopathy manifests, right? So what we should do during the perioperative period. So we have to uh, uh, prevent the patient going into hepatic encephalopathy, and to prevent increase in intracranial pressure, we go for neuroprotective strategies. That is, you keep the head neutral position to avoid kinking of blood vessels, major blood veins, and then avoid compression of neck vessels. So this is to ensure adequate venous drainage and ensure adequate sedation, depth of anesthesia, analgesia, prevent coughing or bucking on the ET tube, and obtain the hypertensive response during intubation, and maintain adequate mean arterial pressure and adequate oxygenation, and control carbon dioxide level to 35 to 40, and avoid high PEEP to prevent the increase in ICP. And you should avoid benzodiazepines and long-acting opioids, which can precipitate hepatic encephalopathy in this kind of patient. And to monitor the pupillary reflex, monitoring of pupillary reflex is kind of a good and easy method to monitor the ICP during intraoperative period as well as in the ICU if the patient is sedated, right? And nutrition-wise, as for any chronic disease, these patients are very sarcopenic. So their muscle mass is very much less, leading to frailty. So the sarcopenia and frailty. Frailty is reduction in functional capacity. So sarcopenia and frailty are independent risk factors to increase morbidity and mortality, perioperative morbidity and mortality. And then, so if the patient is sarcopenic, you will not be able to mobilize the patient. There will be increased ICU stay. You will not be able to extubate the patient early. So there are a lot of problems. And then comes the hypoalbuminemia, which will impair the postoperative wound healing and it will increase the risk of surgical infection. So endocrine-wise, there will be adrenal insufficiency, so which can lead to vasopressor-resistant hypotension in this kind of patient. And they have hyperaldosteronism, as I mentioned, activation of RAS and increased ADH levels. So both this will lead to increased fluid retention. So those are the major systemic effect. Then there's an interesting topic, coagulopathy in liver disease, right? So what we thought initially, we used to think that all the liver patients with liver disease tend to bleed. So is it correct? If you analyze the hematological changes which occur in liver disease, these factors, the factors which promote bleeding, as you all know, your thrombocytopenia, decrease clotting factors produced by liver and vitamin K deficiency, low fibrinogen levels, all these factors will cause bleeding. But this is not the only thing which happens in a liver disease. So there are some factors which increase the thrombosis as well, like increased 1 milliband factor or increased level of factor 13 or decreased protein COS. So there are two things, two entities which is happening in liver disease. So ultimately the patient becomes to hemostatic balance. So these patients can either bleed or they can either not bleed or they can even have increased risk of thrombosis. So you can't decide that all liver patients will bleed. So that is kind of a wrong statement. So again, we used to treat or guide, treat the coagulopathy or guide our management with INR in patient with liver disease. But what you have to keep in mind is INR is not a test of coagulation. So it is a test we do to measure the liver function. So if you take INR, it only measures the procoagulant proteins. It will not measure the decrease in natural anticoagulant. So it will not reflect the tendency to bleed or tendency to thrombose in this kind of patient. So INR is not a guide we should use to manage the coagulopathy in this patient. And on the other hand, if you are going to correct INR, so you will be transfusing FFP. So the dose will be 15 ml per kg, right? So it's a huge volume. So FFP transfusion itself associated with adverse effects of blood product transfusion, as well as there will be a lot of volume, unnecessary volume infusion to the patient, and it can worsen the portal hypertension, causing more bleeding. So INR is a not good measure to manage coagulopathy. So then there will be a lot of pharmacokinetic changes which happens in liver disease. So these are the reasons why there are pharmacokinetic changes. As we discussed, the albumin level is low, which elevate the active or free fraction of the protein-bound drugs, and the volume of distribution will be increased due to ascites and edema, and there will be significant impairment of drug metabolism in liver, which prolong the half-life of drugs. And because of the liver impairment, the first pass metabolism will not take place so properly, like in full capacity, and then this will elevate the systemic bioavailability of drugs. So all these factors will change the pharmacokinetic of drugs. So what you have to keep in mind is you have to be very careful about the doses and the frequency of the drugs you give. You have to titrate rather than thinking about which drugs I should give or which drug I should avoid, right? So talking about induction agent, propofol is safe and very rapid induction, but the problem is in a patient who has already low systemic vascular resistance and impaired myocardial function, it can cause cardiovascular collapse and sudden drop in blood pressure, right? And ketamine is a good option, especially when the patient is hemodynamically unstable. Etomidate again can be used, which will preserve the cardiovascular stability during induction, but even single dose can cause significant adrenal suppression. So these patients are already have adrenal suppression, so you have to be cautious when you use etomidate. And thiopentone is not really recommended because it's highly protein bound. In hypoalbuminemia, the free drug fraction will be increased, causing exaggerated effects. And muscle relaxants, obviously, as you all know, atracurium and cystatracurium will be a good choice because they undergo spontaneous Hoffmann elimination, which is independent of liver and which is dependent on pH and body temperature. But you might have to increase the loading dose because of increased volume of distribution. Procuronium and vacuronium depend on biliary excretion, so it is not very much recommended. And succinylcholine can have prolonged action due to decreased plasma cholinesterase level. And analgesic wise, remifentanil is kind of the best option because it does not depend on hepatic metabolism and it is short acting. And fentanyl also can be used safely. Then there's a concern about using paracetamol. Unless the patient has severe liver disease, you can use paracetamol in reduced doses, right? So it is safe. And tramadol and oxycodone are other alternatives, and regional blocks is like highly safe provided the patient is not coagulopathic, right? So we'll talk about the regional blocks in a while. And then morphine. So we tend to avoid morphine. One thing is it is long acting and it's metabolized in liver and there are active metabolites. So this can, morphine can precipitate hepatic encephalopathy and respiratory failure. So better to avoid. And codeine, again, highly unpredictable metabolic conversion due to the liver derangement, better to avoid. And NSAIDs, absolute contraindicated because of the risk of renal impairment as well as risk of bleeding. Volatile agents, halothane is safe with minimum hepatic metabolism. Desflurane and isoflurane can also be used safely. And halothane, no, it's strictly contraindicated due to the hepatic toxicity. So then when you get a patient with liver disease for any procedure, so we do pre-op assessment and optimization. So there are few core questions we should answer during the pre-op assessment. First thing is you have to know whether the patient is in acute liver failure, acute on chronic liver failure, or decompensation of chronic liver cell disease, because all these three entities carries high perioperative mortality. And if the patient is not on any of these entities, what is the current severity of liver disease, and are there any extrahepatic manifestations of liver disease, or is there active or subclinical infection leading to sepsis? And you have to consider about any other disease-specific considerations as well. For example, patient with autoimmune associated liver disease, they may be on steroids, or they may have autoimmune-induced other organ dysfunction as well. So these are the core questions we should answer in our pre-op assessment. So when you take the history, patient might come and tell that they have a known history of liver disease, or they may not. So if then you can look for classical signs of liver disease, that is jaundice, spider angiomas, palm erythemas. Both these spider angiomas and palm erythemas, unfortunately, we will not be able to see in our population. And gynecomastia, ascites, caput medusae, hepatosplenomegaly, and ankle edema. So these features suggest presence of liver disease. And you have to assess the degree of hepatic encephalopathy. If the patient gives a history of dark urine, pale stool, or pruritus, it's direct towards the obstructive jaundice causing hepatic impairment, or whether there are any bleeding manifestation and chronic alcohol abuse or any other uh, uh, drugs, or this Ayurvedic medicine causing liver injury. And it's worth to check the on-air saturation in supine and erect position to exclude hepatopulmonary syndrome, right, which can be easily done. And investigations-wise, we'll be doing a full blood count to assess baseline hemoglobin and platelet count, and also to get an idea about the ongoing infection. It's worth doing fibrinogen level before going for invasive procedure to make sure that the reserve is adequate. And coagulation should always be assessed by point of care coagulation testing, that is your OTEM or TEC. INR is to assess the liver function. And you can do arterial blood gas to assess the presence of hypoxemia and to check the acid-base balance. And biochemistry-wise, we'll be doing a full liver profile, which include bilirubin, transaminase, and albumin, and a renal panel, that is blood urea and creatinine, to see the baseline renal function, and electrolytes, especially to check the presence of hyponatremia, and also capillary blood sugar. Cardiac evaluation, 12-lead ECG is a must, and you should check the QT interval and 2D echocardiogram to detect the diastolic dysfunction, which suggests the presence of cirrhotic cardiomyopathy, and also to assess whether there are any features of pulmonary hypertension. And CPET, dopamine stress echo, CT, cardiac MRI, CT, depends on the patient basis. So you decide patient basis and depend on the procedure patient is going to undergo. And chest X-ray to screen for pleural effusions. And so it's worth looking at the abdominal ultrasound or CT abdominal imaging to see the degree of ascites, or if you can't find any features of liver disease in your history and examination, you might be able to see it in the imaging. And so this upper J endoscopy. So these patients with chronic liver cell disease undergo annual surveillance of endoscopy, right? So it's worth to have a look at them to check the presence of varices. So once you have done your history examination and investigation, you have to risk stratify these patients, right? So it's a must. So how do you risk stratify these patients? The common scoring system we use is child score, right? So there are 5 parameters we check: bilirubin, albumin, INR, ascites, and encephalopathy. So depending on the value, we give points, and then we calculate the total count. So if the total point is 5 to 6, that is child's A with low risk, 7 to 9 points, child's B moderate risk, and 10 to 15 points, child's C with high risk, right? So the disadvantage of this child score is this ascites and encephalopathy assessment is subjective, right? So the total value, the score can vary depending on the person who assesses. And this score doesn't include the sodium level as well, right? And then you have this lab-based scoring system, that is MEL sodium, and UKL. So MEL include serum bilirubin, INR, creatinine, right? So MEL less than 10 equals to child's A, 15 to 10 to 15 child's B, and more than 15 equals to child's C, right? So if you include sodium into this MEL score, that is MEL sodium, right, which includes sodium as well. And you have UKL as well, again, which include bilirubin, INR, creatinine, and sodium. So in UKL, it gives more gravity to the sodium level, right? So all these scoring systems you can easily calculate using online softwares, right? It's free. And so these MELD scores and UKL scores are mainly used to list or prioritize patients for liver transplant, but you can use them to assess the perioperative risk as well, right? But when you consider this whole scoring system, there are some parameters which are not included in the scoring system, which will predict the perioperative mortality and morbidity. So patient characteristics wise, advanced age. If the patient is elderly, there will be decreased cardiac and respiratory reserve, which will affect the mobility of the patient. And high ASA class, sarcopenia, obesity, all these factors will affect the outcome of the patient, and also thrombocytopenia, presence of portal hypertension, and extrahepatic dysfunction. These are not assessed with this scoring system. And the type of surgery. If it is an emergency surgery, obviously there will be 4 to 5% increase in perioperative mortality risk. So when you risk stratify a patient, you have to consider these factors as well, not only the scoring systems, right? So this is a kind of a guide. Once you have done your risk assessment, this is a kind of guide to proceed. But what you have to remember is this is only for elective surgery, right? When a patient with a liver disease come for elective surgery, you can use this guide. So if the patient is in acute liver failure, acute and chronic liver failure, decompensation of chronic liver disease, then it is recommended to defer, cancel, or consider alternative option, because this category carries high mortality, right? So if the patient is child's A or male of less than 10, you can consider proceeding with cautions, because the perioperative mortality is 10%. And if the patient is child's B or male of 10 to 15, then perioperative mortality is 20%. So you can consider proceeding with cautions post-optimization. So you have to optimize this patient before proceeding. And it's worth sending this patient to tertiary care centers where they can manage if complications occur, rather than doing in peripheral or primary centers, right? And if the patient is child C or male of more than 50, again the perioperative mortality is more than 50%. So again, defer, cancel, or consider alternative option. So mind you, this is guide for elective surgery, not for emergency surgery. So if a patient comes for a maybe life-threatening or limb-threatening situation where you need to do a procedure, then despite of the patient risk, you have to go ahead, right? So how do you optimize these patients? So obviously, always it should be by a multidisciplinary team, which involves hepatologists and specialized anesthetists and critical care specialist, nutritionist, depending on the patient. And then nutrition optimization plays a major role, right? So by optimizing nutrition, we can help with the sarcopenia, frailty, and we can increase the albumin level, which has a good impact, good outcome for the patient. And rehabilitation wise, we usually ask them to maintain light physical exercise to build up a baseline functional reserve, and also incentive spirometry and breathing exercise to help with ventilatory functions. Then how do you optimize the hematology? So as mentioned earlier, transfusion decision should be always guided by your point of care coagulation testing, but not from your INR. So if the patient is undergoing a high risk procedure, we can maintain a fibrinogen level of more than 1 and a platelet count of more than 50,000, right? So we transfuse, we correct the coagulation only if the patient is either active bleeding or going to undergo high risk invasive procedure, or there's an immediate risk for intracranial hemorrhage. For example, if the platelet count is less than 10,000, yes, we go ahead and transfuse platelet to prevent intracranial hemorrhage. So there's no indication to correct the coagulopathy, right? So this is a list of high risk and low risk procedures. So these are the procedures which carries the major bleeding risk is less than 1.5%. For example, central venous catheter insertion or removal, we don't need to correct the coagulopathy, or even transesophageal echo, diagnostic bronchoscopy, we don't need to correct it, right? But if the patient is to undergo high-risk procedures like solid organ biopsies, ablations, surgical dental extraction, then we need to correct the coagulopathy, rotem guided, right? And the other thing is, if the patient during the surgery, you can always go clinical, right? So you can see the surgical field, and then you can ask the surgeon whether there's a coagulopathy or whether it is surgical bleeding. If there's a coagulopathy, you can correct it. But if it is surgical bleeding, there's no point of correcting the coagulopathy rather than to correct the surgical bleed. Intraoperative management wise, as I mentioned earlier, we have to be careful about the induction because the risk of cardiovascular collapse. So be prepared with vasopressors, and then the risk of aspiration. Ascites per se is not an indication for rapid sequence induction, right? So if the patient have other risk factors, or if it is an emergency surgery, then you can consider rapid sequence induction, but not for all patients with ascites or chronic liver cell disease, right? Monitoring wise, pilot ECG to continuously monitor the QT interval, and arterial line should be considered in high risk patients or high risk procedures, where you can closely monitor the arterial blood pressure and titrate your vasoactive drugs. And also you can use the pulse pressure variation or systolic pressure variation to guide your fluid therapy. So we have low threshold for central venous catheter insertion. That is to not to monitor the CVP, but we will need to, most of the time we will need to use a vasoactive drug. So to give vasoactive drug, vasopressor infusion, you will need a CV line. And urine output should be monitored to monitor the renal functions, and then close monitoring of CBS and temperature, because hypothermia can worsen the coagulopathy. And cardiac output monitoring can be considered in selected cases or selected procedures. So you can use esophageal Doppler and transesophageal echo, but there's a risk that these instruments can damage the varices and cause variceal bleeding. So when we use these devices, we do not go beyond the mid-esophagus level because of the risk of variceal bleeding. And you can safely use the flow track, LITCO or PICO to guide your hemodynamics. Fluid selection wise, fluid therapy wise, always should be wall directed fluid therapy to keep the patient euvolemic. And the problem of Hartmann we discuss. And the other thing is use of 4% or 5% albumin to replace the volume in cirrhosis is evidence-based, right? So by using 4% or 5% albumin, we can reduce the amount of fluid crystalloid we infuse and increase the intravascular volume because these albumin solution has some colloid effect, right? So it is good to use 4% or 5% albumin for fluid resuscitation in cirrhotic patient. Noradrenaline is the primary vasopressor choice. You can use vasopressin or telepressin. Ephedrine, metrominol, phenylephrine all can be used, but you have to be mindful about using metrominol or phenylephrine in a patient who is already bradycardic because both these drugs can cause bradycardia. So adrenaline should be avoided because adrenaline can cause splanchnic vasoconstriction, reducing the hepatic blood flow. So CVP monitoring and low CVP strategies for liver resections. And transfusion, as we discussed, should always be guided by ROTEM and always exclude the surgical bleeding, and hypothermia, acidemia, hypocalcemia should be corrected, which can cause coagulopathy. And always guide your correction of coagulation by your clinical findings, right? So, for example, if there's no coagulopathy, if the patient is not bleeding, we don't need to correct the ROTEM, right? So we always observe and wait. And so the other problem is, what is the place for neuraxial blocks and deep regional blocks in patient with liver cell disease? So liver cell disease per se is not a contraindication for neuraxial blocks or deep regional blocks. But if the patient is having a coagulopathy, then there's a risk of hematoma formation in either spinal hematoma, epidural hematoma, or deep hematomas with deep nerve blocks. So should be avoided, right? There's no outcome data. There's no one either general anesthesia or regional anesthesia is not superior to uh, each because both can cause low MAP and decrease hepatic blood flow. So nothing is superior. But if the regional anesthesia is ideal for patient with severe respiratory issues, so you can go for neuraxial blocks and deep regional blocks provided your ROTEM is known. And post-operative management wise, patients undergoing minor surgery can safely manage in the ward. But all the other patients must be managed in the either HDO or ICU setting. So you should monitor this patient for hepatic decompensation, liver derangement, liver failure, sepsis or AKI because these patients are at high risk. And patients should be extubated as early as possible, and sedation and analgesia should be carefully titrated, and always these patients should be prescribed on regular laxatives to promote regular bowel movements. And these patients with liver cell disease are not immune to DVT, right? So even patient may have coagulopathy, but still they are not immune to DVT. So always consider implementation of chemical or mechanical DVT prophylaxis, right? So this is kind of comes to the end of my presentation. If time permits, I would like to discuss two cases. Yes. Right. So this case, these both cases we did like last week. So the first one, this patient was 49-year-old male, known patient with type 2 diabetes, CKD, but not dialysis dependent, and alcohol-related liver disease, chronic liver cell disease, defaulted treatment. So he presented with right lower limb wound. So later we diagnosed it's necrotizing fasciitis, and patient had fever as well. Patient's MET was around 4, and he didn't have jaundice, but there was bilateral lower limb edema, and patient was sarcopenic. And patient had clinically patient had ascites. GCS was 13 to 14, and he had heart rate of 110, and blood pressure was this patient was not on beta blockers, and blood pressure was 110/65. There was no significant finding in respiratory system, and on-air saturation in seated up position was 97%. So the investigation wise, he had a high WBC counts, predominantly neutrophil, and HB was 10.4, platelet count was 61,000. And CRP was elevated, albumin was low, 2.2, and bilirubin was elevated, and blood urea 132, and serum creatinine is 326, but the urine output was adequate. Sodium was 134, potassium normal, INR was 1.5. ECG sinus tachycardia, ABG oxygenation was adequate, and there was compensatory metabolic acidosis with bicarb level of 16.8, base excess minus 6.5, and lactate of 3.3. CBS was 345. So we did ketone bodies to exclude ketoacidosis, which was negative, and there was no previous imagings. And then classification-wise, the patient had chronic liver disease, was decompensating because we suspect the low GCS due to hepatic encephalopathy, and he had ascites as well. So the risk stratification, patient was in child C, the point number, the count is 10. So it's child C, sepsis, had sepsis. He was not on with septic shock, but the sepsis was there, and platelet count was 61,000, and type 2 diabetes, CKD, and patient was sarcopenic, and this is the emergency surgery. So all these, considering all these factors, this was a high-risk patient. But still, we had to go ahead because the patient presented with necrotizing fasciitis, which is limb-threatening situation. So preoperative wise, we took the patient to a HDU and monitored patient, sent the cultures and started antibiotic. We controlled the blood sugar with insulin infusion and hydrated the patient with serofundin. And we did the ROTEM, we showed fibrinogen and platelet deficiency. So we preserved cryoprecipitate and blood. So we took the patient to theater and established standard AG by monitoring, and central venous catheter was inserted under local anesthesia. And we did so we didn't want to do it under neuraxial blocks or deep regional blocks like the sciatic block, because the patient was coagulopathic, which was evident in ROTA. And then we didn't want to do it under general anesthesia also, because the patient had already had clinically evident hepatic encephalopathy. So what we did the case under TCI remifentanil, and then intraoperatively it was uneventful and there was no significant bleeding. So we did not have to transfuse cryoprecipitate or blood. And then we also didn't have to start noradrenaline because the patient maintained blood pressure. And then we sent the patient to ICU for postoperative care. Analgesia-wise, we gave paracetamol, that is 500 milligram as required, and also fentanyl boluses. Antibiotics were continued, guided by culture, and laxatives were added. So we got the hepatology opinion to manage the liver disease, and we regularly monitor the urine output and renal functions. And main problem we had is hepatic encephalopathy, so we had to keep the patient in the ICU for 4 days until it settles. So then patient was sent to ward after 4 days. So he basically recovered without any complication. So this is the second case. Again, we did this last week. This is a 71-year-old female patient with a known history of type 2 diabetes, on insulin, hypertension, and had an inferior STEMI 7 years back. And also known patient is CLCD. We didn't know the cause. And patient presented with sigmoid colon tumor, MET was less than 4. Patient was on antihypertensive, carvedilol, spironolactone, and mixed insulin as well. He didn't show any features of decompensation, but patient was severely sarcopenic. GCS was 15, hemodynamically stable, and saturation on air seated up 99%. So investigation significant findings, so albumin. So initial albumin was 2.2, but after nutritional optimization, it picked up to 2.9, and renal functions were normal, and sodium was bit towards low side, 132. And rotum was normal. 2D ECG right bundle branch was there, and 2D echo, there were multiple hypokinetic segment, diastolic dysfunction, but no features of pulmonary hypertension. Upper GI endoscopy done sometimes back showed small esophageal varices. Right. So the classification wise, this is chronic liver cell disease, not decompensating. Risk stratification, child's B, and other than that, male sodium score was 13, and revised cardiac risk index is 3%, was 3% with 10% of risk of major adverse cardiac events, and patient was sarcopenic, and patient was diabetic on insulin. So those are the risk factors we had. So again, this is a high risk patient. Because the patient was high risk, we discussed with the surgical team, and they agreed not to go for curative surgeries or anything, just to put a stoma and come out. So we altered the surgical plan, and we did nutritional optimization, spirometry and breathing exercises were started, and proper blood sugar control was achieved. And then intra-op-wise, standard AG by monitoring, central venous catheter under local anesthesia, and we did the case under combined spinal epidural. Right? So we did, because the patient rotum was normal. And we had to start the patient on noradrenaline intraoperatively to maintain the blood pressure. There was no significant bleeding, and the intra period was uneventful, and patient was managed in the postoperative ICU, and patient was discharged to ward after 48 hours. Up to now, patient didn't have any complication, but still in the ward. So this comes to end of my presentation. So take home messages wise, always when it comes to a patient with liver disease, either it's elective emergency, always do the preoperative risk stratification, which will help to tailor your management. And if the patient is in acute liver failure, acute on chronic liver failure, chronic liver disease with decompensation, defer, cancel or elective surgery, or consider alternative option. If the patient is child C, it carries more than 50% mortality. Again, elective surgery should be deferred, cancel, or consider alternative option. And never cancel or proceed based on INR alone. And do not correct the coagulopathy exclusively guided by INR. So it should be always guided by ROTEM or TEC, and avoid morphine, long-acting opiates or sedatives, which can precipitate the hepatic encephalopathy. So remifentanil and fentanyl would be better options. Always avoid NSAID, and fluid therapy should be goal-directed to avoid hypovolemia or hypervolemia. So this comes to an end of my presentation. So if you have any questions, I would like to answer.
Actually, I think there is one question posted there in the chat box.
Yeah.
Someone is asking, could you please mention a rough guide about first program drug doses of especially induction agents and other drugs
So
compared to a
actually,
healthy patient undergoing.
Actually, we can't, like, I can't really give a dose. That depends on how bad your patient is, right? So, for example, if the patient is really hemodynamically compromised, you should not be go for high doses. So, right, and if the patient is have low GCS due to hepatic encephalopathy, anyway, you will not need high doses. So, it depends on the patient. Um you can't really give a exact per kg dose for each, for which apply to all patients. So you have to consider individually for each patient how much you are going to give.
And also, the person has asked any difference of doing regionals compared to a healthy patient.
Yes, so if the first thing is, if the patient is coagulopathy, you should avoid central neuraxial blocks and deep regional blocks. So superficial regional blocks, as long as you are competent and you are doing it under ultrasound guidance, you can go ahead. But no deep regional blocks, so the central neuraxial blocks. So that is the only thing, only difference we do. Otherwise, and the other thing I have to mention is insertion of CV lines, right? So when the patient is coagulopathic, you need not to replace the coagulation, correct the coagulation for central venous catheter insertion, as long as you are competent enough to do the procedure. You are doing it under ultrasound guidance and you are not going to puncture the artery, right? So then you can safely go ahead. But if there's a bleeding, later you might consider replacement. Regional blocks wise, the only difference is if there's patient is coagulopathic, you should not go ahead with central neuraxial blocks, so deep regional blocks.
There's another question during liver resection, CVP less than 4 target. Can we able to maintain urine output more than half ml per kg?
Yes, so during liver resection, we usually go for low CVP to reduce the venous bleeding in the liver, right? So most of the time, we think that CVP is mainly affected by your volume. But there are so many other factors which affect the CVP, like your intrathoracic pressure, the intra-abdominal pressure, the position of the patient using the surgical retractors, your PEEP, right? So volume is only one factor which affect the CVP, right? So we restrict volume during the resection phase, maintaining the organ perfusion. We will not compromise the organ perfusion to maintain low CV, right? So you should maintain the renal perfusion while you go for a restrictive fluid strategy. So usually you can maintain the adequate urine output during a liver resection while going for a restrictive fluid strategy. But you have to keep in mind, fluid is not the only factor which affect your CVP.
There is another question which appears, why cannot go with RSI in all ascites patients?
Yes. The thing is, one thing is RSI in our settings, we don't have rocuronium, right? What we have is suxamethonium, which has a lot of side effects, right? Lethal side effects. So suxamethonium is not a safe drug for all patients. And the other thing is, what happens if you encounter difficult intubation during RSI? So if you read the Difficult Airway Society guideline, they do not talk about rapid sequence induction, right? So those are the problems with RSI, right? Otherwise, you can go ahead. There's no contraindication, but you have to think whether this patient really need RSI. Imagine you go for a RSI in an unnecessary patient where it is not indicated, and patient end up with a complication of suxamethonium. Maybe this bradycardic patient can go into asystolic, right? Or maybe you end up with a difficult intubation, right? So that's why I talk about RSI. It is not, unless it's really indicated, it's not really necessary.